recording and hand it off to Dr. Pillsbury. Thank you so much for being here.
Hi, thank you. Thank you for everybody for tuning in. Yes, so we're going to be talking about breast cancer screening and advances in breast imaging. I am a breast imager, so that is what I like to talk about. Okay, first of all, I'd like to thank my darling little rad techs this morning for surprising me with decorating our break room in pink and wearing pink to support me in this talk today and bringing in pink food. And they asked me if I was nervous, and I said I was only nervous that it was going to be boring. And so they said, well, you need to start with some jokes. And I came back to some jokes at my desk. So you can thank them because I've added some funny jokes throughout just to kind of make it less boring, more interesting. And I want to thank them for their support. I think they're tuning in. So our outline today, I'm obviously going to talk about breast screening, screening mammography, because no self-respecting breast imager would have a talk without discussing that, the guidelines, the history, and the importance of it. Then I'm going to mix it up with some little bit more fun stuff and talk about the advances that we have in Barton with regards to breast imaging and new technology. I am also going to wrap it up by talking about breast density and risk assessment and stratification. And that's because we here at Barton have added these things to our mammography reports. And so I just want to make sure that you know why we're adding that, what it means, and what you're supposed to do with that information. A little bit about me. I grew up in Houston with the Houston Oilers. I went to college at the University of Georgia, where I did gymnastics. And then from there, I moved to Dallas, where I trained at University of Texas Southwestern, which is their flagship medical program. And I was fortunate to train under some pretty smart people, including the former president of the American Cancer Society. So that was pretty cool. That is also where I met my husband, Ed, who's also a radiologist, and he is the reason that we moved to Tahoe. We actually moved here, or he took a job here before I had ever even been here. He took a job in Carson, whereas I shortly after that took a job in Carson. We've been here in Tahoe. We live at the lake, but we worked in Carson for the first 9 years that we lived here. And then I was fortunate enough to move to Barton about a year and a half ago. And I've just been thrilled with that. And I feel very lucky to work here. We have 4 kids. That's Kate, little one's Harrison, the medium one's Jake, and little Claire. And so we're happy to be here in our community serving the women that we live with, or I am. He works for a different group. Okay, what I do, because if you haven't interacted with a radiologist, and most people have not, they don't often know what we do. So I just want to discuss it because I have, I'm joking, not joking, that my parents didn't really even know what I did, and they were surprised to hear some of the things that I do day in and day out. So I also had a patient once say, they call you a doctor? And so I want you to know that we, after high school, after 18 years of primary school, we go to 4 years of college, followed by, like any medical doctor, 4 years of medical school. Radiology residency is another 5 years. And then most of us go on to do another subspecialty year of training. And mine was in breast imaging, which was 1 year. So that's a total of 27 years of school, which meant I got my first job in Carson when I was 31 years old. And it might also mean that we are slow learners. I'm just kidding. The modalities that we read X-ray, ultrasound, CT, MRI, PET scans, but we also do we do minimally invasive procedures. So this is just a series of CT scans showing us putting a needle, or someone putting a needle in an abscess in an abdomen. So say if somebody has an appendicitis that ruptures and they're too sick for surgery, they'll call a radiologist to maybe put in a drain and help decompress that and get the patient more healthy to tolerate the appendectomy a little bit later. So a lot of people don't know that. And then we also do biopsies of all varieties. So if it requires imaging guidance, ultrasound, MRI, CT, it's a radiologist that is doing that. So what do I do as far as breast imaging? Obviously, we do screening mammography, both 2D and now, fortunately, we have 3D, which we'll talk about. We also do something called diagnostic mammography. So screening mammography is for people with no symptoms. Diagnostic mammography is for symptomatic patients, including problem solving. This is where we often lead to a cancer diagnosis. Amongst that, one of our tools is ultrasound. There's a picture of an ultrasound pointing at a little mass there. And we also have breast MRI. These are all the tools in our toolbox. And very recently, we have added contrast enhanced mammography. And this is the most cutting edge thing that we have to offer in the field of breast imaging. And we have it at Barton. So we will tell you all about that. So diagnostic mammography, just to give you an idea, if you had, say, come into my office with a symptom, be that maybe you had a mammogram that I called abnormal and I want more pictures, or maybe you have a lump or pain or something else. So you would come in with your symptom. I would order additional imaging and go over it with you. That would sometimes lead to a biopsy. I would call you with your results and go over those with you, send you to the appropriate doctors and surgeons and oncologists and whoever, and get you on the road to recovery. So that's a day in my life. Moving on to the importance of screening mammography. So the purpose of any screening exam has to satisfy 3 criteria in order to be considered a good screening tool. So find the cancer before it's symptomatic. It's got to be undetectable by any other way other than this screening method. Not only that, but it has to improve your outcome. So if it doesn't lead to a better outcome and more years of life, then it's meaningless that we found it earlier. And of course, it has to be at an acceptable risk, expense, and availability. And I say all of that because mammography is one of the best screening tools that we have in medicine. I mean, there's colonoscopy and now maybe some lung cancer screening, but by and large, this is the golden example of a good screening tool. This is a standard mammo view where you have 2 views of each breast. This is the right breast and the left breast, and we squish it between a plate with the force of what I'm told is about that of a car battery, and take a picture in 2 different planes from top to bottom and from side to side. And so I just need the men to know that you need to be nice to us on days that we have screening mammograms. And it is not a fun exam, and there's nothing that you have that's equivalent. So be nice to us. Okay, what are the ACR screening guidelines? If you remember nothing from this lecture, start at 40, get one every year, and don't stop getting them. There's no upper age limit. If you're in good health, you still need to be screening for mammograms. The American College of Radiology has also added now a recommendation that all women should have a risk assessment by the age of 30, especially African-American women. And that's because a lot of women would qualify for earlier screening than the age of 40. African-American women more often get cancers in their 30s. They're more aggressive, they're more advanced stages. So we definitely want to ask that question by the age of 30 of how soon should you specifically be getting a mammogram. They've also sort of taken away the self-breast exam and introduced something called self-breast awareness. They don't want you going in and mashing around. Patients were finding too many things that weren't real and too much anxiety. So now they say self-breast awareness. Check it out, get used to what you feel like, what your body feels like, and just monitor for changes rather than a monthly exam. You still should be getting a yearly exam by a trained healthcare professional. And they've also come down hard on MRI and high-risk screening. We'll talk a lot more about high-risk screening, what the risk stratification, what that means at the end. But suffice it to say, there is a recommendation for that. And they've also recently put out a transgender screening recommendation set. So basically, bottom line, if you have breasts, you need to be screening them. And if you're a male to female trans woman, then you've been on hormones for 5 years, same rules apply. If you're 40, you need to be getting mammograms. Most important. Okay, so I have had a lot of patients over the years having a lot of excuses or questions, I guess, as to why they don't think they need to have a mammogram beginning at age 40, or why they don't need a mammogram anymore because they're, 75 or whatever. The problem is there's been a lot of confusion because other governmental and medical groups have been putting out different recommendations for the past few years. And I'm not going to go over them because I don't want to confuse you. But basically, all of these organizations agree that annual mammograms beginning at 40 save the most lives. They're willing to accept higher death rates in a certain population, namely the 40 to 50-year-old women, in order to save number of mammograms. So we stick to the tried and true 40 yearly recommendations, and know that by law, your insurance companies are required to pay for annual screening mammograms beginning at 40. And as I said, most of the controversy and guidelines begins or hinges around that age at which you start, which is at 40, and they want to start screening later. But you need to know that a fifth of all cancers, breast cancers, occur in women in their 40s. So if you're going to cut out women in their 40s, you're going to miss a fifth of cancers. And these are the women who are the youngest. They have the most years ahead of them. They have their careers, they have their kids. So these are the women that we actually should be focusing on. And I always kind of tongue in cheek say, if you plan to live another 8 years, you need to be getting a yearly mammogram, because I was taught that it takes about 8 to 10 years for a breast cancer to kind of run its course. And trust me, you do not want to die of breast cancer if you can help it. So just get them and we can treat them. So there are still people out there who, like I said, don't believe that breast cancer screening is maybe worthwhile or effective. So I love this slide. I'm not going to belabor this, but I love this slide. This came from the American Cancer Society website. They do publications of all cancers analysis through, and they do it every year. And this is a graph from year of death rates in women and the year. So they started monitoring it in the 1930s. We started implementing screenings in the 1980s. And for the first time in history, so this is a flat line, it's bouncing around, but nothing meaningful is happening. And 10 years after we start screening, we start to see a precipitous decline in death rates in breast cancer. So as I said, it takes about 10 years to die from a breast cancer that you didn't know about. So we caught these cancers starting here. These patients stopped dying like they would have 10 years later. So this is interesting also because this is not mirrored in men who don't get screened. Men with breast cancer still die at the same rates. They're not being screened. So we can reasonably believe that the screening is making the difference. It's not the treatments improving, although they have improved and continue to improve, but the screening is what made the difference at that time and continues to. So that's translated to nearly 300,000 lives spared. And that's because it's easier to treat them when they're smaller, before they're detectable as a lump. And 5-year survival rates reflect that, as the smallest cancers are now at 100% survival, 5-year survival rates, compared to much lower for advanced larger cancers. So in other words, thanks to the help of screening mammography, breast cancer is now often curable. And the overall death rate has decreased by 43% in the past 30 years, and it continues to decline. This is the last fact slide I'm going to show, but it's also from the American Cancer Society. It's not from 2017. I didn't update that. It's from this year. It's estimates for death for new cases and death rates for this year. So it is still the leading cancer diagnosis in women year over year by a long shot. I mean, it accounts for a third of cancers in women. Nothing is even close to that. So that's 300,000 women per year. And it is one of the highest, it's the second highest cancer killer, double anything else nearly, except for lung and lung. So it is common and it is deadly, and it affects a lot of people. So 300,000 people will be diagnosed per year and 43,000 will die per year. That's 1 in 8 women. We've all heard that. Importantly, most women, 3/4 will have no family history. So that is not a reason to not get screened if you have no family history. And going back to the by age, so 20% of cases occur in women in less than 50. And this is because the breast cancer rates start to double for physiologic reasons. In the late 30s and early 40s, that's when the risk of breast cancer start going up in women. Okay, so 75% of the women in their 40s that die of breast cancer are in the non-screening population. So we do not want to be in that population. Okay, so moving on to sort of more fun stuff, new technology and additional screening options. I took this slide from an old presentation where I used to get this question not infrequently. What about thermography? I think there was a doctor in Reno that had bought a thermography machine or something and you wanted to use it, but it's not good. It's not proven to do anything. These are the only 4 methods that are proven to be effective in breast cancer screening: 3D mammograms, breast MRI, breast ultrasound, like screening breast ultrasound, and contrast enhanced mammography. So forget anything else. It doesn't work. 3D mammogram, now the new gold standard. This is, people call them 3D, and medically, I think that the word is tomosynthesis, similar to CT, like CT stands for something tomosynthesis. It's the new gold standard. It is a much better mammogram. They've now been around for over 10 years, and we've just really learned that they do a really good job. They decrease the effects of masking, which I will talk about later, but basically means it's harder to see cancers in certain breast types. And 3D accounts for that and makes it an equal playing field for all women. And it increases the overall sensitivity. So the ability to see cancers is increased when you do 3D mammograms. And interestingly, also the rate of false positives decreases. So it increases the specificity, meaning what I see on a 3D mammogram, I can be certain is real rather than a fake out, which is a common phenomenon on 2D mammograms. So it helps save people having to come in for additional imaging when nothing is wrong. And comes at only a minimal increase in radiation dose. So it's really, really a great addition to or improvement on mammography. How is it done? Well, for the patient, it's a similar experience. You're still going to get the CC and MLO views in compression, but the difference is that instead of one picture from the top, your mammography machine is going to swing around and take a bunch of low dose pictures at different angles. It's going to put it in the computer and come up with what looks like a regular 2D mammogram. Over here, it'll give me like this computer generated machine picture of what I'm used to looking at. And then it gives me a bunch of images that I can scroll through. And this is them just kind of splayed out. Usually they would be stacked and I can just scroll through them. What that does is it sort of gives me an idea if something is overlapping as normal tissue, or if something is overlapping right here, you can sort of see, oh, that looks like a mass. Over here, you're not really sure, kind of looks similar to everything else. But as you look through, that just stands out. And actually for the first time, I was like, oh, that actually stands out too. So we would then want to definitely send this woman to ultrasound and see if we could find a little mass there, because at this point I would be worried about it. This is some examples of the difference between 2D mammograms, 3D mammograms. This is one slice, maybe probably out of like 60 slices, where you can't see anything in here. Everything looks fine. It just looks like white tissue. And then right here, you start to see, oh, there's a mass there. And it has little, we call them spicules, like it's sharp. And this is what a cancer looks like. So that cancer was found on the 3D picture, and it would not likely have been found on a 2D picture. This is another similar example where it just does a really good job of showing the architecture in a way that you wouldn't regularly see it. I mean, you can't see this is not different than this. It looks the same. And over here, you can just see it's radiating out like a little star. And this, again, is what cancer looks like. Okay, so I mentioned screening breast ultrasound, and this is a modality that we used to rely on in denser patients and in certain populations that maybe couldn't have an MRI. And we used to use this, and we know that it does find more cancers. This is sort of a schematic of what an ultrasound probe looks like, and it would be up against your skin, and it sends sound waves down, and they bounce back, and it receives them and generates a picture. It's helpful because it's not radiation, it's fast, it's cheap, it's no risk to the patient, and it's real time. So I can go in there and I can look myself. And because of the nature of the sound wave, you get to learn characteristics of the mass that aren't readily available on the X-ray images. So a mass that looks like this and this look the same on an X-ray, whereas on the ultrasound, you can clearly see, because this is fluid, the sound is going straight through it. This is fluid, it's benign, it's fine. This is gray, it's solid. This is also gray and it's solid, but this is different margins. We talked about those stars. So that looks a little more concerning. And then this is bright, and that means it's benign. So we don't care about that at all. There's two different types. It's not really important. Automated and handheld. In Reno, they have an automated machine, so they use it. I can tell you it's not great. There's no technologist in there scanning, so you often have to bring the patient back. It's user dependent. It's not great. So, okay, in 1999, they did a really large scale study, and they did find that ultrasound finds more cancers. So maybe we should start screening, right, by ultrasound. However, the thing is that it leads to 8 times as many biopsies. Biopsies had an extremely low likelihood of being cancers. So that is unacceptable to have to biopsy 8 times more people to find, one more cancer. And then the good news was that in that same study, they found that MRI found 2 times as many cancers as mammogram and ultrasound combined, and concluded with fine, ultrasound may be appropriate for some women, but really by and large, MRI is better than both. We have now recently discovered that contrast enhanced mammography is also better than both. So, kind of the take home point is screening breast ultrasound is probably a thing of the past, and there are much better ways to screen than ultrasound, including these studies were done without 3D mammograms. So ultrasound is good for a lot of things, but screening is probably not one of them. Okay, so what about MRI? This is a schematic of what it looks like. So you would go in, sorry, I made last minute edits and they didn't save. So you would go into the machine face down on your stomach, your breast would fall through holes called a breast coil. You'd have a little hole for your face. This is a picture of our happy little MRI tech over here. Once you're in there, they'll inject you with contrast called gadolinium based. It's different than CT contrast. And they take pictures of your breast at 4 separate time points. And there it is. What that gives us is something called neovascular data, which basically means characteristic of the blood flow going on in your breast. The idea being that cancers have robust but disorganized blood flow, and benign lesions have more organized blood flow, or if there is no mass, you won't see anything there. You also get a little color flow graph that tells you the characteristics of how fast the thing gets blood flow and how fast the blood flow leaves. And that is meaningful with regards to detecting cancers and detecting benign masses. So this is just an example of obviously 2 breasts. This is grossly abnormal, and it gives you a little color map. So red is bad, green is also bad, blue is typically okay, but this is obviously just not right, and it's very easy to see on that picture. So advantages, well, you get a picture, you get a 2-for-1. You do one study, you get both breasts, you get extra anatomy information. So you can see the ribs on here, you can see the lymph nodes on here, you can see some of the bones on here. So you're going to get some extra information there. And then you also get some composition characteristics for certain lesions. So you can tell on an MRI if something is fat or water, and fat and water means it's non-cancerous, so you wouldn't worry about that. You can also, they're like volume images, so you can manipulate them in 3 views, so you can kind of get a better look and a better understanding of where it is in space. It takes about 30 minutes, but they are now coming up with abbreviated protocols, which are proving to be pretty darn good. So that is something to look out for in the future. And here's another example. This is just kind of like, we'll get a graph for a color flow, and that will map to a color. It makes it really more simple for us to interpret. So just examples of little masses on MRI here. So as I said, MRI does detect 2 times as many cancers as mammogram and ultrasound combined. It is the gold standard, as I said, for high-risk screening in high-risk women. Generally, those women will stagger 6-month screening with mammogram, 6-month screening with ultrasound. So they're getting screened twice a year instead of just once a year. It's also great for known cancers to look for additional things that might have been missed on the mammogram or might not be detectable, and also to look at the opposite breast. It obviously, like any test, has limitations. It's expensive. It's uncomfortable. Patients who are claustrophobic have a hard time tolerating 30 minutes in there. Some patients have metal implants, including like a pacemaker or a nerve stimulator, and they can't get an MRI. There's a new phenomenon where the gadolinium, which is the contrast that I mentioned, can deposit in parts of your body. It's not known to cause harm, but some people are uneasy knowing that. And so they don't want to do that. And then a very small fraction of patients will have an allergic reaction to the contrast. And then it's not available everywhere. So the other thing is there is a phenomenon called background parenchymal enhancement. It is different than breast density and they do not match up, but the idea is similar in that if you have a breast like this, all this white stuff is what we call enhancement. It's the dye going to the normal breast tissue, and this normal breast tissue just enhances a lot more than this person's. And there's no reason for it, and it doesn't really matter from that patient's like health standpoint. It just makes it harder to see little masses. So it's a limitation that we know of. And then finally, even if you're being screened by MRI, you still will have to get a screening mammogram because mammograms can show things that MRI can't. They're namely calcifications is a big one, and calcifications is a sign of earlier breast cancer that you want to catch sooner. And MRI is not good at picking up those. So bottom line, gold standard for high risk screening. Here's some examples. Here's a mammogram. This is the right breast. There's obviously a mass. This is most likely a cancer. This is her mammogram. She's got a lot of dense tissue. You can't see that mass at all. You would never know that it's there until it got much bigger and was able to be felt, but she got an MRI and they found it. And then this is almost certainly a cancer and very asymmetric. But now you have all these other little masses here that MRI is showing, and it's extending places that you wouldn't have otherwise seen it. So it's really good in certain situations like that. Okay, finally, contrast enhanced mammography. And this is like fresh off the press. I mean, contrast enhanced mammograms, I would say we offer this at Barton. This is our little mammo suite with our cute little mammo tech. And this is the contrast portion. So it's just the same regular mammogram. Let's see. It's same as a mammogram, same experience, except for we inject you with contrast and then we wait 2 to 10 minutes. You can take pictures and then you do a 2D mammogram. And what the machine does is it simultaneously takes a high energy, uses like high energy x-rays and low energy x-rays. So it takes 2 simultaneous exposures. This is the low energy one. It looks just like a standard 2D mammogram. And this is the high energy one. And lo and behold, you can see a mass that you could probably have seen it there, but wow, it just jumps right out at you on that picture. And that also has to do with the neovascular data, that whole concept of cancers being vascular. And it is also minimally added radiation, similar to a 3D mammo. So radiation is really not a problem. And similar idea to MRI. Like MRI, it has in early studies shown to be as effective as MRI in finding 2 times as many cancers as mammography alone. It also is better at MRI at identifying benign things, so actually leads to fewer benign biopsies. So yet again, in this field, we found 2 things that have improved finding cancer and decreased false positives, which is a rarity in a field like this. Okay, what are the advantages in contrast enhanced mammograms? Well, they overcome the dense breast tissue problem, similar to MRI. They're also overcome some of the MRI problems we talked about, like claustrophobia. I mean, this is fast. Patients are not in a confined space, and it's a lot cheaper than an MRI. And you get the advantage of having a 2D mammo at the same time. So it's a one-stop shop. It's happening in the department that we already are used to doing mammograms in. Obviously, it has some limitations as well. It has iodinated contrast, which is similar to the CT contrast, which also is known to have rare allergic reactions and rare problems with renal function, affecting your kidneys function. It also has the BPE, the background parenchymal enhancement problem, because it sort of, I mean, it's the same idea as MRI. So It's the same thing with background parenchymal enhancement. You may not have dense tissue, but it is very vascular. And it does not give you the added look at the chest wall that the MRI did, and the bones and the lymph nodes and things like that. So that's it compared to MRI. And here's some examples of what contrast enhanced mammography helps us with. So you would never see these little masses in this tissue here, but this is the high energy, this is the low energy. So this looks like a standard 2D mammogram. You can see that there's some lymph nodes up here that are not normal, but you can't figure out why until you look at this one, and it's pretty obvious. Like there's 4 little masses there. This is a person who is post-operative. She had cancer and she had a lumpectomy. And this is her tissue on the 2D, and on the contrast enhanced, you see all these little stair-step masses. So at this point, you're highly concerned that she's got a recurrence that would have otherwise gone unnoticed. What are we using it for? I've told you it's so new. There's really not a great understanding of where it should be used, and from a billing standpoint, I mean, the FDA hasn't even approved it for screening in regular patients. So we're using it primarily for problem solving. We can use it for, we know it's good. It has been studied, and we know it's as good as MRI in evaluating known cancer. Not approved for average risk women in screening, but it is proving to be really promising in a certain subset of women at intermediate risk for breast cancer. I'm going to talk about that in a little bit, but it's women with a 15 to 20% lifetime risk. And up until contrast enhanced mammography, we have not really known what to do with that group of women. We knew what to do with high risk women, right? We said MRI, 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 but what do we do with the intermediate risk women? And so this is proving to be a really good solution for that group of women. And for high risk women who can't or don't want MRI for all the reasons we've already talked about. Side-by-side comparison, this is a 2D mammogram. You know, awfully hard to see it on this in retrospect. I mean, I think it's pretty obvious, I guess, but the 3D does a much better job. It's very, very obvious on this one. But wait, there's another mass that we would never have seen. This is the contrast enhanced, showing us so much more information than we had before. So there weren't really any funny memes about breast density. So I took that to mean there's nothing funny about dense breasts, but we will talk about it. So why are we talking about this? Why is this in the news? Why does everybody care? Well, basically because it started becoming law around 2013. A woman on the East Coast got breast cancer, or was diagnosed with breast cancer 6 months after a normal mammogram. And she was told, well, we couldn't see it on your mammogram because you have dense breasts. So she, wanted to campaign for these women who are getting a false sense of security, being told that they don't have cancer when in fact they might have cancer and they just can't see it on their mammogram. So this became state law in a lot of states beginning in 2013. California was one of the first ones to make it law. It became federal law just this year. So now it is federal law that we as radiologists have to tell the patients in our reports, as well as by letter, if they have dense breast tissue. And we're putting things in our reports that are very scary. This is the letter that we send out. Dense breast tissue can make it harder to evaluate the results of your mammogram and may be associated with an increased cancer risk. The verbiage that we're required to use includes may obscure small masses. Your breast tissue lowers the sensitivity of mammography. These are all really scary things, and they're confusing, and they cause anxiety because you don't know what to do with that information. Great, okay, I have a normal mammogram, but it may obscure small masses. Like what? And this is affecting a lot of people. I mean, it's basically half the population, 2 million women in California alone. And here's just a website if you want to go and find out more information about it afterwards. And I found on this website this interesting legislation that is in the early stages called Find It Early Act. And I liked it because it would require insurance companies, require payers to pay for diagnostic imaging in women that are at higher risk and or with dense breast tissue. So that's what, that's would remove one of the barriers that women have to finding access and getting their breast cancers diagnosed. So that would be wonderful. So if you're interested in that, just go to densebreastinfo.org. Okay, so fine. I have dense breasts. What does that mean? What is breast density? So they have us as radiologists divide women up into 4 little buckets, and it's basically by quartile as to how much white breast tissue you have. So the white stuff is what we're looking at, and this is called fibroglandular tissue, and its ratio to the black stuff, which is fatty tissue. So if you have very little fibroglandular tissue in relation to fatty tissue, then you have fatty breasts, and that's less than 25% of your breast composition is fibroglandular tissue, and it goes up from there. So 25 to 50, you're in this category, category B, and they have names. The top 2 are dense breasts, heterogeneously dense and extremely dense, and we arbitrarily cut this in half and call all these people dense and all these people not dense, when the reality is it's more of a bell curve, and 80% of the population is going to fall between here, with 10% outliers on either side. So it's also not a very reliable measure, because it's a human putting these people in these buckets. And so it's a judgment call. And they've found that even that judgment amongst the same radiologist changes year over year. And amongst different radiologists, I think it's this and he thinks it's that. So I try not to worry too much. I try to tell women not to worry too much if they're in one of these 2 categories or if they're in this category. What we really need to focus on is the extremely dense 10% of the population. So let's talk about that. Factors affecting breast density. Bottom line is you can't really affect your breast density. It's not anything you did or could change. It's mainly how you're built. It's genetic, and to some degree it's age related, and it does tend to go down with age. But it's also affected by hormones. So of course, if you take hormones or if you take hormone blockers, that's going to change your breast density. And if you gain weight, then you're going to gain fat. So that's going to increase your black tissue with relation. So that may help a little bit, but it doesn't really change, and it doesn't really matter from a lifestyle standpoint what you do. Why does it matter? Well, cancers are white. If you haven't picked up on that, they're white. They look like little white masses. So if you have more white tissue, you can't see the white cancers. They say it's like hunting for a snowman in a snowstorm. And so then these masses have to get much, much larger before you can see them in this extremely dense breast. And these you can't see at all in this heterogeneously dense breast, but you can tell it's already gone to the lymph nodes. So they're further along, and you just do a poorer job detecting them. As far as sensitivity, so mammography is not perfect. It doesn't catch 100% of cancers. They say it will catch about 88 to 90% of cancers in that category 1, the fatty, or category A, the fatty breast tissue. And then the ability to detect the cancers goes down from there. So if you have extremely dense tissue, you're going to miss quite a few more cancers than if you have fatty tissues. That's just how it works. And so then it also has an innate increased cancer risk, because the white tissue is the functional tissue of the breast. That's where cancers are made. That's where they arise. So if you have more of that type of tissue, you're going to have a higher chance of forming a cancer. That risk is increased by about 1.2, not much, in the category C, the heterogeneous tissue, but it is over double. You have over a double chance of forming a cancer if you have extremely dense tissue. So you have higher chance of forming it and lower chance of catching it. That number, I've seen this number actually as high as 4 or 5 on some websites, but I quoted this little table, which is a Byred's table, which is like our Bible. So I believe this number over something as high as 5 times as likely. So what can we do? Fortunately, this campaign has led to some improvements in technology, right? 3D mammograms do a great job. They increase the sensitivities across the board by like 20%. They say they get this number back up to this number. So these women don't have as much to worry about if they're getting 3D mammograms. And what do we do about the increased cancer risk? Well, we've moved towards formal risk assessments. Lots and lots of facilities now are including a formal risk assessment as part of their mammogram workup. because you're already providing all the history information that we need. It's not a genetic test. It's just an algorithm that you plug in. You can do it online. You can go to a website and do it yourself. We do it for you. And then we're starting to, at Barton too, include it in our report. So this is the tool that we're using at Barton. It's called the Tyrer-Cuzick scale. There are multiple scales out there. We're using this scale because we got with the surgeons and the OBGYNs, and we are all using the same scale. This one, unlike the other ones, accounts for your breast density. So we liked that. It'll ask, we put in all of this information. It spits out a little sheet that looks like this. We include it in your chart, and we include this number in your report. What is your personal lifetime risk? This is what is going to determine which category you're in. And this is mine, and I am high risk because I am over 20%. So what does that mean? There are 3 little baskets that we fall under. Average risk women are less than 15% lifetime risk. Unfortunately, it's pretty easy because it's 15 and 20. Those are the 2 cutoffs. So intermediate risk women that I was talking about earlier are between 15 and 20% lifetime risk. And the high risk women are over 20%. Good news is if you're average risk, which most people are, you require no additional screening. Just get your screening mammograms, you're fine. If you're high risk, we know what to do with you. We put you in MRI yearly or now contrast enhanced mammography. If you're in intermediate risk, I was saying we never really had a good answer for that or good clear recommendations. We were doing whole breast ultrasound. It wasn't great, leading to all these biopsies, but now we have contrast enhanced mammography. And I think that's just going to be the answer and the wave of the future for these intermediate risk women, which is really great. Quickly, I included this slide because I find it incredibly reassuring. I just want you to know how federally regulated mammography is, and that's due to this act, Mammography Quality Standards Act, which enacted in 1994, basically ensuring that everybody's doing it the same and everybody's doing it right. You can't just go buy a mammography machine and offer mammography. It has to be, it has to follow all of these FDA mandated compliance regulations. It has to be accredited every year or every 2 years. You have to sustain or go through annual audits. Your doctors that are reading for you have to read this many mammograms every 2 years and do this much CME. And then on your audits, you have to prove that you're doing a good job. We audit how many women we call back from a mammogram for additional pictures. We audit how many women we ask to biopsy, and then how many cancers we find. And if we're not meeting these benchmarks, we're not doing a good job. So I just think that that's really special and unique to mammography. And we should give everybody a little bit of comfort knowing that you're getting good care and somebody's making sure of that. Okay, I'm almost done. The Barton Breast Center is because of all of, we're a tiny little hospital, but we have such great equipment and resources. It's truly one of a kind. We're the only one in the basin that offers all of these things, technology, the 3D mammogram, MRI, contrast enhanced mammography. I didn't even talk about our seed localization, but we basically have services that rival large academic centers. We have excellent surgeons. We can satisfy all of your needs. Okay, a little Halloween humor for you. So in conclusion, screening works, do it annually, beginning at 40, don't stop. Breast density, know yours and what that means. Risk assessment and stratification, you're going to get this in your reports. So pay attention to what your number is. We're going to have recommendations that are tied to that number. Mostly going to be contrast enhanced mammography because it is just so great. And all of these advances, we are proud to offer all of them here. Okay, that's it.
Awesome. Thank you so much. That was excellent. I just want to remind folks that if you do have questions, you can ask them in the Q&A box or the chat box. We already have a couple that have filtered in, so please get those in. The first one is, would a contrast enhanced mammogram happen as a diagnostic after a 3D tomographic mammo? So a lot.
That's a good question. And I don't have a very straightforward answer. It at this point is at the discretion of the radiologist. certain things would absolutely benefit by having a contrast enhanced mammogram afterwards. It's something called architectural distortion that's really vague and doesn't really look like a mass. And maybe you can't find anything under ultrasound. You would certainly consider sending that person to contrast enhanced mammogram. The other thing I didn't mention about it is that its negative predictive value is really high, meaning if it doesn't show up, you can be reasonably sure that it's benign. So it's helpful in ruling out things like that and hopefully sparing biopsies that don't need to happen.
Great. The next question, do smaller breasts mean less risk?
I would say I am not sure about the answer on that. It probably has to do with, I would say probably to some extent, because you're going to have less tissue and you know, certainly if you have small breasts with extremely dense tissue, then no. I would say that the density probably matters more than the size, and your underlying risk factors matter more than the size.
Great. We have a hand raised, so I'm going to allow, I think it's Naomi, to talk. Hold on. Go ahead if you can unmute yourself. Let's see. Well, she's figuring that out. The next, let's see. Sorry, Naomi, if you hear this, you can go ahead. We've started to let people raise their hand. So if you want to raise your hand and talk and ask that way, we can try that as well. But we'll go ahead until she can maybe get going to see what the next question is. You mentioned that breast cancers are 75% not related to genetics. So how should someone know if they should be concerned before 40?
That is the purpose of the risk assessment by the age of 30. And, primary care doctors are they are aware of this and they are doing them. Many 30-year-olds don't go to the doctor regularly, so they are available online. But if you have a risk assessment that puts you in a high risk category, you certainly would want to find out if that means you should start screening sooner. And typically it does. If you're at high risk, we don't do mammograms younger than 30, but if you're at high risk and say you had a family member have a breast cancer in their 40s, you would like to start screening 10 years before the age at which they were diagnosed.
Got it. I haven't seen any other questions. I'm still seeing if Naomi wanted to talk, but I'll start to wrap things up. If you do have a question, you can sneak it in there and I'll ask it for you. But just a reminder that this presentation was recorded tonight. So if you want to go back and watch it, it will be on our YouTube channel, probably by tomorrow. And there will be a post presentation survey. We love hearing from you on how we did. And if you have topics that you'd like to hear more of in the future. I haven't seen any other questions come in, so I will go ahead and give everyone their 9 minutes back tonight. And Dr. Pillsbury, thank you so much for the great presentation. We really appreciate it.
Thank you.
Have a great night.
You too.